DNA damage response orchestrates a complex network of mechanisms that detect and repair damage to DNA, such as DNA double-strand breaks and replication stress. However, when DDR defects occur, it actually promotes uncontrolled cancer growth and enables cancer cells to evade and escape apoptosis. We now have approved drugs. We actually have 4 approved PARP inhibitors in the clinic right now. And whilst we have seen great success, we really need to build on the success of this first generation of PARP inhibitor monotherapy agents. And the reasons for that are that, not all patients with BRCA1 or BRCA2 associated cancers will respond. And even if they do, drug resistance is nearly inevitable. And so there's really great potential to try and deepen the responses, to increase the durability of responses, and also ultimately to really widen the application of PARP inhibitors and other DDR inhibitors. And we're really now building on that success on these first generation PARP inhibitors. And that's really been facilitated through the discovery of novel precision targets that have been enabled by modern cancer genome sequencing and CRISPR technologies. And these strategies have really allowed us now to use biomarker-driven patient selection strategies to guide clinical development in the clinic. And therefore, the whole DDR therapeutic landscape is rapidly expanding beyond PARP inhibitors. We now have ATR, V1, ATM, DNAPK, CHEK1, RAD51, PARP1 selective inhibitors, and also newer ones such as PKMYT1, POLθ, and USP1 inhibitors. And we've shown at this meeting that next generation PARP1 selective inhibitors such as AZD5305 really do help to improve toxicities versus the first generation inhibitors. They can actually achieve much higher drug exposures in the clinic as well. Really nice PK, nice PD. And the hope here is that we will also build on the efficacy of the first generation inhibitors and also enable better, more effective combinations and better tolerated combinations as well. And as mentioned, we have multiple inhibitors against ATR, V1, and beyond, which are all targeting different patient populations, different tumor types, different molecular subtypes, and ultimately they all have different pharmacological profiles and are all at different stages of development. And for me, the key priorities now for DDR inhibitor development is really to try and optimize the pharmacology of these new drugs, improve on molecular and tumor type patient selection, and ultimately to achieve a greater therapeutic index in our patients and improve on patient benefit, and in the development of multiple rational DDR inhibitor combination strategies.